Assalamualaikum. Good morning, everyone. Hope everyone is healthy and in good condition during this MCO period. Okay, because of this COVID-19, so I'm going to do my first e-learning style of teaching. Okay, so the topic that I'm going to cover today is anemia in pregnancy. Okay, I've shared reading material in the e-learning. So there's textbook of obstetric, essential obstetric, and there's guideline of UK management about anemia in pregnancy. I hope you have read it, and my lecture or my slides today, I'm going to teach you how to tackle it in clinical scenario, meaning how when do you see your patient in the wards, in the clinics, how you're going to approach them. Okay, all right. I hope everyone is ready. Okay, anemia in pregnancy. I give to you Madam Zakia or Kakia, a 30-year-old Malay lady. She has no medical illness, okay, and no family history of blood disorder. Her menses is regular and normal, and currently she's pregnant at 9 weeks period of amenorrhea. Okay, she did her booking. Her height is 160 centimeter. Her weight is 60 kilogram. Urine albumin is negative. Blood is O positive. Her hemoglobin is 12 gram per deciliter. That's normal. Okay, infective screening is negative. Okay, so normally doctors and nurses will advise the patient for hematinics. Okay, and usually patient will ask why. Because she's normal, right? Her hemoglobin is normal and she's not losing any blood. So how do you answer to that? Number one is to tell her that iron requirement in pregnancy is increased because of the red cell expansion, for the fetus placenta, the blood loss during delivery, losses in sweat, urine and feces, and the net requirement is very high. Okay, so the increment from non-pregnant states is around 2.8 milligram per day to 6.6 milligram per day in pregnant state. Okay, next you will tell the mother the complication of anemia in pregnancy. Okay, so that they understand what are the consequences if they don't take the hematinics. Okay, maternal consequences you can divide it into three: antepartum, intrapartum, postpartum. Antepartumly, she might have preterm labor, intercurrent infection, preeclampsia, cardiac failure if she has severe anemia. Intrapartumly, she might have DPH, cardiac failure also, or shock. And postpartum, she might have increased risk of puerperal sepsis, poor lactation, peripheral venous thrombosis, and pulmonary embolism. Okay, in fetal consequences, the baby might have fetal growth restriction, and the worst case scenario is intrauterine death. Okay, the patient will need the medication. So normally you will give 4 medication that is comprises of ferrous fumarate, vitamin C, folic acid, and lastly is vitamin B complex. So patient have to take one by one 4 medication. So to ease the patient, so there are now medication that consists all of this vitamin, such as in USM we have this Obimin. Okay. But then patients sometimes they go and buy with a private clinic or the pharmacy, for example, and there's a lot of other product there in the market. It's okay. as long as it consists all of these vitamins. Okay, finally, you have to tell the patient why or the factor affecting the iron absorption. Okay, the acid secretion in the stomach will increase the absorption, such as the acid, and patient also we are giving vitamin C to increase the absorption. The state of the iron, and then the more that the deficiency of the patient, the more the absorption will be. Right? The most important is what decreases the absorption. Prior to pregnancy, many lady who like to drink tea or coffee. Right? So here you can see the tannic acid, and then coffee reduces the absorption, so you have to avoid this one. And then other things such as antacids, magnesium, zinc, copper, this all phosphate in the eggs, and some herbal, peppermint and chamomile, is reduce the absorption, so try to avoid these things. Okay, now Madam Zakia is 20 weeks pregnant. Okay, she claimed compliance with hematinics, but surprisingly her hemoglobin is reduced to 9.6 gram per deciliter. So what do you expect the patient? Of course she will anxious. Okay, so she will ask what is the diagnosis of her. Okay, why her hemoglobin dropped despite she was taking hematinics? Because you explained just now everything, she just follow, but hemoglobin still dropped. And what are the treatment? Okay, first we go to definition of anemia in pregnancy. Okay, according to UK guideline on management of iron deficiency in pregnancy, anemia in pregnancy is defined as first trimester hemoglobin less than 11 gram per deciliter, and in the second or third trimester is less than 10.5 gram per deciliter. Okay, anemia in pregnancy can be divided into 3 stages. Okay, mild, moderate, severe. Okay, for example, the severe is less than 7 gram per deciliter. So these are for the management of the anemia in pregnancy. Okay, so what do you investigate? Okay, number 1, you want to take full blood count. Okay, number 2, you want to take full blood picture or blood smear, and number 3, you want to take a serum ferritin. Okay, from the full blood count, you want to look at mean cell volume. Okay, why? Because if it is 80 to 100 femtoliter, this is a normocytic anemia. If it is less than, this is less than 100. So this is less than 80, It's less than 80 is a microcytic. If it is more than 100, it is macrocytic. And then you also want to see the MCH to determine whether it's a chromic of anemia. Alright, then from the full blood picture, okay, full blood picture, you want to see this special RBCs shaped like a pencil. Okay, because they will suggestive of iron deficiency. Okay, if it is a teardrop and target cell, this is more on thalassemia. Lastly, the serum ferritin level. Okay, so it's closely related with your total body iron stores. So if it is less than 12 nanogram per ml, it is specific for iron deficiency anemia. Okay, so Madam Zakia, investigation showed A full blood count shows normal MCV and normal MCH. The serum ferritin is 20 nanogram per milliliter, and a full blood picture showed normocytic, normochromic red cells. Okay, so what is the diagnosis now? It is a physiological anemia. Okay, so there's another category of anemia. You can divide it into physiological anemia or pathological anemia. On pathological anemia, it can be caused by nutritional, hemoglobinopathies, chronic disease, and malignancy, bleeding, infection, and inflammation. Of course, in our case just now, she's a physiological anemia. So the question is, what is physiological anemia? So physiological anemia is when you increase blood volume but decrease blood viscosity. So this is to facilitate the fetal perfusion. Okay, all right. So you can see here the total blood volume increased to 40%, plasma volume increased to 50%, red cell volume increased up to 30%, but hematocrit is reduced by 2 to 3%. So these are why it's a physiological anemia. It's a normal thing to happen during pregnancy. Okay, so our patient came now at 30 weeks period of amenorrhea, right? Her full blood count showed hemoglobin of 9.1 gram per deciliter, reducing and with low MCH and MCV and MCH. Okay, the serum ferritin now dropped to 10 nanogram per ml. Okay, full blood picture showed pencil shapes and teardrops, RBCs. Okay, what's your diagnosis now? Yes, it is iron deficiency anemia. Okay, so according to the UK guidelines, okay, when a patient diagnosed to have a iron deficiency anemia, the treatment is she need to have elemental iron of 40 to 80 milligram every morning. Okay, so what is elemental iron? Okay, elemental iron is the contained iron that can be absorbed in the human body. All right. So if it is, for example, this ferrous fumarate, there are 210 milligrams of iron, but the absorption is around 65. The elemental iron is 65 milligram. The ferrous sulfate of 200 have 65 milligram of elemental iron. Ferrous gluconate 300, very high, but the elemental is only 35 milligram. Okay, the albumin now, our patient is taking albumin. Look at the elemental iron inside there, only 10 milligram. Okay, so it's not enough for her, right? What about sangobion? Only 30 milligram. Ganylea, only 30 milligram of elemental iron. So if you notice, these three, Ibarat, zinc copper, and maltopher, they have 100 elemental, 105, 115, 100 of elemental iron. So these are the medication to treat iron deficiency anemia. Okay, so Madam Zakia was started on zinc copper, 1 tablet daily. Right. After 2 weeks of medication, her repeated HB is 9.5. Okay, just still anemia. And then when we asked about the compliance, she claimed she can't tolerate the medication. Because iron, you have this problem of metallic taste, constipation. Okay, right? At 34 weeks period of amenorrhea, she's still anemic. So what to do now with her? Give already oral iron therapy, but she cannot tolerate and she's still anemic. So the answer to that is parenteral iron. Okay. So the UK recommendation, if the patient are intolerant or do not respond to oral iron, You can prescribe IV iron, intravenous iron. At least she is more than 34 weeks gestation and her hemoglobin is less than 10. Okay, these are the example of parenteral iron. Interferon, Jactopher, Venofer, and sodium ferric gluconate. Okay, so these are the medication names. Iron dextran, iron sorbitol, iron sucrose. In HUSM, we are using the iron sucrose, which is the Venofer. Okay, it can be given IM or intravenous. Lastly is the blood transfusion. When is you want to start blood transfusion in the patient? These are the indication. If the patient have severe anemia, HB less than 7, and the pregnancy around more than 36 weeks, or patient who are failed in parenteral iron therapy, patient who are going for low segment caesarean section, or patient have symptomatic anemia. She have dyspnea, palpitation, reduced effort tolerance, so you have to do blood transfusion in her. Okay, I think that's all about how we manage anemia in pregnancy. Okay. So I hope you can understand my lecture just now. So that is how, basically, roughly how we manage the patient clinically. Okay, please do your reading. I just pray that this movement control order will be end up soon. And I want you all to stay safe at home and keep social distancing. Hope to see you soon in the classes. Okay, thank you and Assalamualaikum.